Next presentation is from Dr. Sierakov, who is going to present his experience with Silk Vista baby stent.
It's up to you. I'm going to be really, really quick, if you let me speak. Sure. So good morning, good afternoon, my name is Alex Sierakov, and today I have the honor to speak about something that I'm truly passionate about, and that's flow diversion, and especially low profile flow diversion. Is the click working? Oh yeah. So no conflicts of interest, unfortunately. This is the overview of the presentation in the main agenda. Today I will do my best to share some tips and tricks and maybe some technical specification and considerations when it comes to the Silk Vista Baby, which is a relatively new and recently introduced flow diverter stent. Of course, I'm going to do my best to entertain you with a few case examples included, complications, etc. So this is a rhetorical question, no doubt. I think we all agree about that. We do need a new flow diverter that is dedicated for distal anatomies, and especially aneurysms that are located beyond the circle of Willis. And the reason is that the majority of the flow diverters that are currently and commercially available are not meant to be deployed above the distal ICA. If you open the brochure, if you open the technical specifications of the pipeline, of the thread, or maybe the surpass device, you see that the on-label application is limited to the internal carotid artery. Now, the limitation comes from the fact that those stents, they don't have the available sizes for distal anatomies. It is rarely the case that you have like a middle cerebral artery or anterior cerebral artery above 3 millimeters in diameter, which means that the devices are now not meant to be open in vessels below 2 millimeters in diameter. Of course, there is some issues with rigidity, deliverability, resheatability, etc. So another technical standpoint and another limitation of the current portfolio of flow diverters that we have in our shelves is the fact that they're mostly compatible with 0.21 and 0.27 microcatheter technologies. This is extremely troublesome if you have to navigate a 27 catheter across the ACOM-A complex, especially in distal ACA, or maybe, let's say, posterior PCOM or PCA, or any distal vessel, MCA bifurcations, etc. So there is the point where we need actually a new flow diverter, and I think that's a perfect example and a great addition to our shelf and current armamentarium. The design is notorious. I think we are all aware of the design. It's a DFT technology that binds 48 wires into a very stable mesh. Despite the fact it's made of a DFT technology, it is relatively stable with a good radial force that ensures adequate wall position in the majority of the cases. Something that I'm extremely big fan of this device is the pusher wire. It's made out of nitinol and it's extremely kinky resistant. For example, the other options that I am aware of, for example, the P64MW, its wire is extremely bendable, and that can create you some headaches while we're pushing the stent in, especially in distal anatomy. The DFT technology and the presence of platinum actually allows you a greater visibility. You can see the stents and the complete integrity of the stent during deployment. You can see all the components. You can see the distal wire. You can see the mesh. You can see the part of the stent that is actually coming out of the catheter, or the part of the stent that is still inside the catheter. You can clearly see the proximal marker that ensures up to 90% of resheatability. Not gonna lie, I've never tried this. I've allowed myself to recapture a device that I've partially unsheated up to 70%. Of course, I'm not a risky person, or at least Tanemir doesn't allow me to recapture the stent. In terms of capabilities, by the book, it's compatible with gamma 17, and we are stick to gamma 17. This catheter is slightly more notorious about its rigidity, but you get to use it. You'll be at least happy once you deploy 10 to 15 gammas distally. It provides good stability for the deployment. Of course, according to the literature, the stent is actually compatible with all the available 0.17 catheters. That includes the Echelon and the SL and the Headway, but I think we've never tried it. Now, in terms of sizing, the portfolio of the Silk Vista Baby basically encompasses stents with diameter from 2.25 to 3.25 millimeters in diameter with variety of lengths. That ensures that the majority of the distal aneurysms that you have in your daily practice are going to be treatable with the flow diverter stent. Some practical aspects and maybe some technical considerations about this stent. You should be aware of some proximal shortening, but that's common feature for the majority of the flow diverters, maybe besides the thread. A little bit more prominent with the Silk Vista Baby, but if you follow the general rules and the common sense when it comes to flow diversion, just to ensure that you have 4 millimeters distally and 4 millimeters proximally to the aneurysmal neck, you'll be in no trouble for sure. Just position the stent wisely, don't dampen curved segments or the widespread bifurcations, and you have no technical issues. So, for the sake of entertainment, I've prepared a few cases, and I'm going to squeeze them in the following 4 minutes at the end of my presentation. This is a patient that we treated in acute SAH, and of course it's a ruptured, let me just point it out. It's a ruptured ACOM aneurysm with a residual, with the residual that we noted on the follow-up. As you can see, I'm not a huge fan of stent-assisted coiling in these scenarios, and I'm gonna be honest with you, maybe I'm not skilled enough to position an Atlas stent to gel a catheter in safely, not to misplace the coiling catheter, and if you do that, you're gonna be in huge trouble. I prefer to put a gamma and then deploy a flow diverter stent that fully covers the aneurysm without any complications. This is the final post-deployment angio, and in the follow-up, you can clearly see the remodeling of the aneurysm. It's completely gone 3 months later. Complete occlusion. Yes, you may say there is a small instant stenotic changes, but they're not significant and clinically silent. This is the tubular integrity on the treatment and after the control. Little to no changes on the tubular structure of the flow diverter implant. The second case is almost similar. Two ruptured aneurysms that we failed to coil the distally located one, what we successfully coiled the proximal one that's located on the ACOM artery. Some residual was also noted during the follow-up, and we were eager to try the Silk Vista Baby in this setting, in this configuration. Distal navigation was performed, and of course we managed to safely place the stent. As you can see, it's clearly visible on fluoroscopy. You can control the whole situation. Something that I extremely like about this stent is the tip of the delivery wire. It might look sharp, edgy, and pointy, but believe me, that's not the case. Even though the other alternatives, if they have a movable wire or not, this one is extremely soft. I think there are some colleagues in Turkey that actually recommend you can easily pre-shape the wire before deploying the stent to ensure distal navigability and for more comfortability to the vessels. But so far, we're extremely happy with the tip. This is the stent deployed. Unfortunately, the patient is about to come for a follow-up, so I'm not able to show you the complete occlusion, and I believe in the complete occlusion here in this case. A very recent case that we did like last week, a dissecting and relatively large PCA aneurysm in a symptomatic patient, or radiologically symptomatic aneurysm. There was perifocal brain edema on the temporal lobe. We were really careful with this aneurysm because dissecting morphologies are often associated with complications. Of course, you guys are going to agree that you can place an Atlas stent, you can put a few coils, but we consider this a technically demanding procedure, especially in posterior circulation or especially in dissecting anatomies. This is why we decided to proceed with the implantation of the Silk Vista Baby, distal to proximal, fully covering the aneurysm. We carefully select the proper sizes, slightly oversized it, make sure we have enough landing zone, and we've deployed the stent, as you can see on the video. We took our time. I mean, the stent is being deployed with the common push and pull technique, nothing irregular. Over here, we were not really satisfied with the proximal landing, but after a few maneuvers with the microcatheter, you can see that we actually made it a little bit more comfortable to the PCA anatomy and push it out of the basilar artery. And here's the navigation of the microcatheter that ensures optimal wall position and that the device is fully opened. This is the post-contrast angio, no distal emboli, no thromboembolic or any other technical complications, and you can see the wonderful eclipse sign with the contrast media stagnating inside the sac. That confirms that we have a durable flow diversion across the neck. Another case, another partially coiled aneurysm. We were really skeptical about this case because I'm not sure you can see, but there is a slight stenotic changes inside the neck of the aneurysm. We were not sure that the device will properly open. We deployed the stent and we saw a critical deformity just at the level of the neck. But after navigating another adjunctant device to make sure that we perform stent angioplasty, the stent was beautifully open without any complications. And you can see the patient came for a 6-month follow-up, and the MCA bifurcation was completely reconstructed with no tubular changes to the implant on the follow-up, which is amazing in my opinion. Another asymptomatic MCA aneurysm that we consider technically challenging, of course, extending and wide-standing on PCONUS devices, webs can be the solution here. However, we proceeded with the Silk Vista baby from covering the lower branch, the neck, and ending up in proximal M1. And you can see the end result. That is 1 month later. The patient came from another ICA aneurysm on the other side. You can see that the aneurysm already diminished in, let's say, two-thirds of its volume, which is amazing, with no deformation on the stent seen on the follow-up. That's one of the two complications that we had with the stent. Basically, I think the learning curve with the device is here to be blamed. We were too cocky to undersize the stent. Most probably we didn't measure correctly. While we were deploying the stent for this MCA aneurysm, we saw that the tubular integrity of the stent has dynamically changed over the course of 5 minutes. You can see that there is some sort of a proximal fish mounting, and the stent was progressively closing, and that could end up in a devastating complications for the patient. Of course, we managed to selectively navigate inside the Silk Vista baby with another catheter and placed an open cell laser cut stent that ensured that the stent will remain open. So far, the patient is asymptomatic without any clinical consequences. But we'll see about the aneurysm for sure. So for almost 8 months of period, we managed to squeeze up to 50 flow diverters in our practice. You can see the anatomical distribution. Yeah, there was one patient that experienced transient ischemic attacks, but they were resolved after application of glycoprotein injections or intravenous antiaggregants. One minor technical issue that I've presented to you, the foreshortening, but this was basically related to the learning curve, and maybe the idea is that you need to measure twice before you actually unseal and open the stent on the table, but that's common sense. In conclusion, this is a very good toolkit that you need to have in your shelf, and you need to start getting a use of it. Thank you.
Thank you, Dr. Sierakov. Are there any questions from the room?
I have a question.
Hello.
Wonderful presentation, thank you. What tools are you using for measuring the stent? Do you use 2D? Do you use 3D? As you say, this is always the question.
Yeah, that's a tricky question, and thank you very much. Listen, if we have the chance to perform a 3D, of course, we're going to measure it on 3D. Otherwise, we prefer to get a proper working selection projection. A selective one, and we measure the stent in 2 dimensions and 2 projections AP water, and we're satisfied with the results so far. We always stick with the rule to oversize, and I'm a big fan of the longer stents. I mean, why would you end up in the wrong side with the stents being placed inside the aneurysm, or you miss the landing zone, etc.? That's a common sense. But yeah, when we have the opportunity to measure on 3D, we do it on 3D. We don't use any sophisticated softwares, and yeah.
Thank you. Absolutely agree.
And even though the longer stents are more crucial to not expand properly, or maybe to...
Yeah, I get it. It comes with the risk. It comes with a certain price, but that's our job, right? That's part of our job.
Sometimes...
Why you are fond of longer stent?
Because it's safer in my hands.
Why you think that it is safe?
because
I just want to understand your, approach.
sometimes catheters, when you navigate the catheter distal enough, there is anatomical distortion of the artery. It might look slightly elongated. And once you start to deploy, there is a fear in my head that I might miss the distal or the proximal landing zones. So selecting a longer stance, from my technical standpoint of the clinical expertise, it's the better choice. I know it's more metal. I know I'm covering more vessels, and the longer stents, they actually are more prone to introduce instant stenotic changes. They're more prone to be twisted, to be fish mounted. But I fear that I'm going to lose the landing zone. That's the honest answer.
Yeah, that is an important fear. That the landing zone.
Yeah.
That is kind of a feature. You can combine this technical ability of what you have. That's why every material we have, including Silk Vista, has advantages and disadvantages.
For sure.
That's why it should be evaluated under the knowledge of what we have technically. Thank you for your explanation.
Pleasure.